So if you have a disability, it's one thing. And so you have to struggle with lots of challenges. But what about complex marginalization? What I mean by that is, so what if you're not only disabled, but also you're homeless? We did work in the US looking at the situation of people living in shelters, living on the street, with various disabilities, and didn't get the services that they required. They didn't get timely access to healthcare services. They didn't get safe access to healthcare services. They get a lot of complications as a result of not having a lot of preventative or routine care services and access. They often were medication was stolen often, or prescriptions were stolen in shelters, or sold on. Equipment fell in disrepair, couldn't be repaired, and providers didn't come to the shelter necessarily. Sometimes the sanitary conditions were difficult. The only accessible shower in one of the shelters that we visited broke down, and so wounds, pressure ulcers, and things like that was likely to become infected, were not cleaned, was not kept clean, or couldn't be kept clean. So people were frequenting emergency room services at a higher rate than they needed to. And this quote, actually by Joe, says it all, I think. I had a nurse refusing to come here to the homeless shelter because of the conditions of the place. She refused to come on the floor because it was not sanitary enough for her to come in here. When you hear a healthcare provider saying that, then I think it speaks for itself. So just hanging this. We saw similar pictures around people who had been exposed to violence, gun violence particularly. Young people, 17, 20 years of age, get shot, had a spinal injury, and after rehabilitation get chucked out onto the street or ended up in nursing homes and didn't receive any follow-on services. So those groups, those people at the margins of society, like Janice here works at the moment on a study that we're doing looking at maternity access of women with disabilities, but who also are victims of domestic violence and domestic abuse. So that's another group that's invisible, that might be voiceless, but I think we see it as a responsibility to create these voices and bring them to the surface. Fernando's here, who's doing a lot of work around homelessness in Dundee, and we also included a disability question there to see if we can collect some data locally on them. So we need voice. So in conclusion, I think we have a legal obligation, so I come back to that. We have a legal obligation, a legal mandate to fulfill this mandate of equitable, affordable access to healthcare. It's a human rights challenge, and we have to meet those challenges. And if we're failing to include the voice of people with disabilities in health-related research, as we discussed, then we cannot guarantee their safety. We cannot guarantee the effectiveness of the interventions that we're producing. If we are failing to include them in quality improvement efforts, like the ones I illustrated with patient-reported outcomes, we're sending a message that a substantial proportion of the population doesn't matter to us in quality improvement. So I think we can do better, and we don't have to put people's lives at risk. And I think it's important to include the voice. I think I learned that personally very early on in my life. I was invisible to healthcare providers when I was 16, and I lay in a hospital bed and I was threatened with amputation. And so people were talking across the bed and said, well, I think we should probably remove the leg. I was invisible. Nobody consulted me. and involved me in any of the discussions or decisions. And I went to my parents actually, who, against the medical advice, removed me from the hospital. And on their own risk, they had to sign that, of course. But the health professionals didn't listen. And I think we need to make them listen, and we need to not only work with the professions, we need to work very closely with the disability community to bring healthcare back onto the agenda. Thank you.